Good day, everyone. My name is Mehanna, and I'm lucky today to interview Dr. Espay, Dr. Marsili, and Dr. Kauffman about their recently published paper, Resolving Vascular Parkinsonism, COL22A1 as a Genetic Adult-Onset Leukoencephalopathy. This paper was published in Parkinsonism and Related Disorders in 2023, so feel free to go back to it for more details. So Dr. Espay, could you tell us something about vascular Parkinsonism?
Sure, Raja, thank you so much for having us. This particular paper was important to us because in the past, we've been concerned about this idea of what Parkinsonism is from a vascular perspective. And it turns out that vascular Parkinsonism as a diagnostic can be made using the so-called Silchman's criteria that were created in 2004, and essentially is three-part criteria. Part one requires the presence of a vascular disease. Now, this is the judgment based on an imaging abnormality, usually created in the CT era, but just in the MRI era of an increased signal in the periventricular and deep white matter. Part two is what's called a lower body Parkinsonism that we are concerned about because the most likely scenario in most of these patients is not Parkinsonism, but a higher level gait disorder, so a cognitive gait. And part three is a connection between the two. So it's a very simple diagnostic criteria, and unfortunately, therefore, leads to an over-diagnosis of vascular Parkinsonism. Now, the key concern regarding the validity of this is that in the two clinical pathologic case series, one of which actually was used to get us into this entity, the relationship between the actual vascular pathology and the symptoms was very poor. And when you take out individuals who have had pathology that we today would use the term Parkinson's disease, that's synuclein pathology, or we can use it for multiple system atrophy. In fact, you are left with very little of a relationship between whatever vascular abnormalities there may have been in those individuals labeled with vascular Parkinsonism and the clinical pictures. And then the final concern about this is that if there is indeed a vascular Parkinsonism that would then be related to vascular risk factors, that the stringent control of those, hypertension, hypercholesterolemia, diabetes, etc., would lead to an improvement in the features, or at least a reduction in the progression. And this is not true. So we have a condition for which we think the connection to vascular disease is very poor, particularly the standard vascular risk factors we know about, and that in which Parkinsonism often is a higher level gait disorder. And this figure that you see here was published also in Parkinsonism and Related Disorder, and it emphasizes that when we think of vascular Parkinsonism, the true definite vascular Parkinsonism is a lesion in the midbrain, in the area that relates to the nigra, and that leads to a hemi-Parkinsonian state. Anything else that we refer to as vascular Parkinsonism may be either Parkinson's with Luca or iosis, the nature of which we often don't appreciate or understand. That could indeed be true microvascular disease. But then in many cases, what happens is that we are dealing with other conditions. In some cases, we see increased white matter signal periventricularly in individuals who actually have normal pressure hydrocephalus. But now it's increasingly recognized that the same picture can be seen in individuals who have an adult onset genetic leukoencephalopathy, is well described in CADASIL, in CSF1R related leukoencephalopathy, and COL4A1 related leukoencephalopathy. So our assumption is that there may then be conditions that are genetic that manifest with what today we call vascular Parkinsonism, and the case report that you are highlighting, Raja, would point at least to one such etiology. And I'm going to let you take it from here to present the case. And this will be Luca, who actually did a lot of the work, along with Marcelo Kauffman, who is also joining us.
Thank you. Thank you.
Thank you very much. So Dr. Marsili, on that, what was the phenotype on the case you reported?
Yes, so this patient came to our observation a few years ago. She was a 69-year-old woman with a 2-year history of imbalance, shuffling gait, and ultimately falls, with some forgetfulness, word finding, and naming difficulties. So some short-term memory loss, not really relevant at that point. With dysautonomia, mainly incontinence, orthostatic hypotension, associated with mood depression since long time before, 40 years, treated with duloxetine, with also restless leg syndrome, treated with a low dose of ropinirole since 5 years prior, and a recent onset of anosmia, but no hypophonia, hypomimia, or microgravity. Her past medical history was relevant for arterial hypertension and breast cancer many, many years before. No history of smoking as a risk factor, and an important family history of Lennox-Gastaut syndrome in her 2 children, developmental delay in a maternal cousin, congenital blindness in another cousin, stroke in her mother, and relevant dementia associated with leukoencephalopathy, so white matter disease, and gait impairment in her father. She was a retired librarian since 16 years prior. Here I want to show you the video of the first neurologic examination that occurred about 2 years after the disease onset. As you can see, there is a kind of impairment in her gait, not that relevant at that point, mostly on the left side, with some shuffling of her gait. Nothing more at that time. At the pool test, she had some hesitancy, but she was still able to recover. Then we have the neurologic examination videotape 6 years after the disease onset. And again, here you can see the worsening of her gait. So what Dr. Espay was referring before with really high level gait disorder, mostly white-based, with some dragging of the left foot. There is also reduced arm swing on the left arm. So kind of a worsening of the gait pattern and more unstable at the pool test maneuver. So here she's still able to recover, but there is more hesitancy and difficulty in the recovery. The postural reflex are kind of compromised. Here you can see the brain MRI of the patient 2 years after the disease onset with the white matter disease involvement, the diffuse leukoencephalopathy without the bleeding evident at the gradient echo scans.
And at this point, the diagnosis was?
Vascular.
Okay.
Great, thank you. So Dr. Kauffman, what did you find on genetic analysis?
Thank you. Good day, everyone. Yes, we performed whole exome sequencing for this patient, this intriguing patient suffering from vascular Parkinsonism. We found a variant that was classified at the time of our report as of uncertain significance, but it was pretty clear for us that it might be considered a good candidate for pursuing with further studies and functional studies. This variant is located in one of the genes coding for different collagen-related genes. This gene in particular codes for the type 22 alpha-1 chain of collagens. There were many signs that this variant can be involved in the pathogenesis of this case. Starting from the rarity of this variant, its absence from population databases, and the consistent prediction of a deleterious impact for different orthogonal bioinformatic tools that were used in the interpretation of the exome, and especially because it was located in one of the main functional domain of the collagen proteins, in this case, the collagen triple helix domain that is crucial in this case for collagen function, and it has been previously associated with pathogenic mechanisms in this gene. All of these signs heightens the chance of its potential pathogenicity. But we need to pursue the functional study because it was first in its history description of a variant in this particular gene for leukoencephalopathy or for vascular Parkinsonism. So we studied with colleagues about the functional role of this variant. This involved the generation of a zebrafish model where this variant was introduced, and it was modeled and assessed its potential function. And as you can see in the right part of the slide, this variant confer a particular susceptibility to hemorrhage. So the embryos from this model showed a greater chance of hemorrhage, and that might be indicating a vascular instability conferred by this alteration in collagen. So considering now all of the particular features of the variant, and especially the functional impact of this particular variant, we conclude that this variant very likely might be involved in the pathogenesis of the vascular encephalopathy for this patient.
Great, thank you so much, Dr. Kauffman. So Dr. Espay, in conclusion, why do you think this case was informative?
Yeah, so this case provides to us at least the proof of principle that individuals that fulfill criteria for vascular Parkinsonism, which I think are very non-specific, can be in fact looked into for the possibility that they may have a genetic leukoencephalopathy. In this situation, one that was previously undescribed, called 22A1, although plausible because there is another protein called 4A1, as you see here, which can give rise to somewhat phenotype reminiscent of the one we had, although there is a very wide spectrum of manifestations, as you can see from this slide. I think from our perspective, the message that we wanted to convey is that when we think of this idea of quote, lower body Parkinsonism in the context of white matter abnormalities, it is important not to jump into the idea that vascular Parkinsonism may be a diagnosis. It's really just a way that in the past we were able to make sense of this phenotype. Now we know that with the advent of advanced genetic technologies, we can in fact identify the true etiology, which in many cases will be genetic. Keep in mind those lists here, CSF1R, COL4A1, Catacil, and interestingly, in a Taiwanese series, it's shown that Notch2 NLC is now perhaps the most prevalent cause of genetic leukoencephalopathy in Taiwan. That's 20% in the last report. So that's a very large proportion of patients. So I think we just, as clinicians, need to be mindful of this. In the future, we will be able to move past the genotype into the molecular biology. And if we know what the genotype is, we will be able to understand what those individuals are affected molecularly, and therefore a disease-modifying intervention could be potentially in the horizon. So that to us is the most important relevance of this case. And I hope that this will be important for clinicians everywhere to keep in mind as they approach their patients with a similar phenotype.
Fascinating. Thank you so much, Dr. Espay, Dr. Marsili, and Dr. Kauffman, for walking us through your article. For everyone listening, reminding you that the article was published in Parkinsonism and Related Disorders, and it's available there for more details. Thank you very much again.
Thank you, Raja.
Thank you
for having us.
Thank you.
And cut, as we say.
And